But we started this study where we essentially took patients who were going to get a procedure called a left heart catheterization to take a look at the coronary arteries and see if there's a blockage, stratified by patients who had clean coronary arteries, didn't need any intervention, and patients who had a significant blockage that needed a stent. We got a rectal swab before the procedure for all of them for what's called 16S sequencing and metabolomic sequencing, essentially looking at the types of bacteria that grew, the diversity of bacteria, and then any downstream chemicals that were made as part of their natural metabolism to investigate any kind of you know causative association that there may be between certain chemicals and disease entities. And so we had an N of 50 for enrollment, and at or after patient 47, COVID hit in full effect. I actually took care personally in the medical ICU of the second COVID patient in the United States. So I hang my hat on that. But funding, as would be expected and appropriately so, got diverted because there was a once in a lifetime pandemic. The idea stuck with me and was further bolstered by conversations I had with some of my mentors at Tufts while I was a cardiology fellow, specifically head of transplant, who was really interested in what happens with dysbiosis or deleterious gut microbiome alterations in heart failure. And there was evidence coming out to that effect, kind of supporting that dysbiosis does contribute to cardiac disease, and that alleviating it or targeting it is kind of the next frontier in addressing inflammation. There's actually a paper that came out when I was giving my seminal talk as a third year fellow, and had this conversation with my mentor, Dr. Best, in JACC heart failure. That was kind of narrating what we know so far, what there is to know, and how this is essentially a very promising track in terms of addressing residual risk, or the gap between what we can predict in terms of who will develop cardiovascular disease and who actually does. We've
Mm.
gotten better at it, but there's still that residual risk. There's still that gap.